It's time for another warm-up. Let's get going. What are the clinical uses for cephalosporins? So for the first generation, the mnemonic is PECK, P-E-C-K. So that's Proteus mirabilis, E. coli, Klebsiella pneumonia. And then don't forget the gram-positive cocci, which is, again, the main uses for these. The second generation of cephalosporins, we're adding on HEN, so H-E-N to our PECs. And that's going to be the mnemonic. The H is for Haemophilus influenza, then Enterobacter, then Neisseria species. And then again, still the PECs. That's the Proteus, the E. coli, the Klebsiella, and that's very important. You also have an S at the end of this one as well, and that's to help you remember Serratia marcescens. And again, don't forget the gram-positive cocci. Third generation cephalosporins are primarily for serious gram-negative infections. Think of Pseudomonas and for Neisseria gonorrhea as well. And then your fourth generation cephalosporin, things like cefepime, that's the big gun. It's going to work well against gram-positives and against gram-negatives like Pseudomonas. Next, what lab finding helps with the diagnosis of giant cell arteritis? So the lab that keeps you to make that diagnosis is that elevated SED rate. But for a definitive diagnosis, you actually need to get a temporal artery biopsy. All right, that's it for the warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichal here, and welcome to Micro by Systems 3. We're going to have a lot to cover here, so let's just dive right in. First, let's talk about congenital infections, which pass from the mother to the baby either during pregnancy or during delivery and often cause congenital malformations. The mnemonic for these is TORCHES, which isn't the greatest mnemonic in the world, but it sticks, and this is a 4-star topic, so you need to be familiar with these. TORCHES stands for toxoplasmosis, other, which includes parvovirus B19, rubella, CMV, HIV, HSV, and syphilis. Many of these are really only problematic if the mother has a primary infection during the pregnancy, meaning that it is the first time she's exposed to the infection in the pregnancy. And a lot of these cause the same cluster of complications like growth retardation, intellectual disability, hepatosplenomegaly, or even miscarriage and stillbirth. So let's focus on what's unique about each of these. Toxoplasmosis is caused by the protozoan Toxoplasma gondii, which is transmitted by handling cat feces, which is why we tell pregnant women to avoid the litter box. You can also get it from eating undercooked meat. The classic triad for congenital toxoplasmosis is chorioretinitis, inflammation of the choroid and retina in the back of the eye, hydrocephalus, and intracranial calcifications. The O in TORCHES stands for other, which is technically could just be about any infection, but specifically I want you to remember parvovirus B19. In children, parvovirus B19 causes erythema infectiosum, or Fifth's disease, which is the slapped cheek rash that later spreads to the chest and shoulders. In adults, parvovirus can cause arthritis, but in fetus, parvovirus B19 likes to infect the blood cell precursors, and this can result in severe fetal anemia, which eventually leads to high output heart failure, hydrops fetalis. Hydrops fetalis is basically where the baby has fluid accumulation in different parts of the body, like ascites and pleural effusions. R is for rubella, which in children causes German measles, which is basically a mild fever with discrete maculopapular rash that begins at the head and moves to the trunk. But congenital rubella is much more serious. Congenital rubella causes cataracts, patent ductus arteriosus, sensorineuronal deafness, and other classic finding in congenital rubella is the blueberry muffin rash, although this can be seen in other conditions. Here's a neonate with congenital rubella, and you can see that he is covered with dark macular lesions like blueberries in a blueberry muffin. These are areas of extramedullary hematopoiesis. C is for CMV, which is the most common of the TORCHES infections. CMV is widespread, ubiquitous virus that can cause mono-like syndrome in kids and adults. Fetal CMV infection can produce a lot of non-specific findings like jaundice and hepatosplenomegaly, but one of the more common findings is sensorineuronal hearing loss. So, if they give you a pregnant woman with a mono-like syndrome and her baby has hearing loss, think about CMV. The H in TORCHES is for two things, HIV and herpes simplex virus. With these two, we worry more about transmission during labor and delivery rather than during pregnancy. So how do you prevent HIV transmission from the mother to the infant? Well, the mother should be on antiretroviral therapy. And then, unless she has a pretty low viral load, you want to give zidovudine during delivery, and she'll deliver by C-section. After delivery, the infant is given zidovudine prophylaxis, and finally, the mother will need to be counseled to avoid breastfeeding. Breastfeeding is contraindicated during HIV infection because the virus is definitely shed in breast milk. Herpes simplex virus was the other H. What we're worried about here is the virus being passed to the baby through direct contact with the birth canal and vulva during delivery. Congenital HSV infection can cause a vesicular rash in the infant and possibly a non-purulent conjunctivitis with keratinitis as well. But you can also get pneumonia, a CNS infection, herpes, meningoencephalitis, or even disseminated HSV and a sepsis-like picture. So how do we prevent transmission in the pregnant women with a history of herpes? We give acyclovir to suppress the HSV and prevent outbreaks starting at 36 weeks gestation. And if that doesn't work, and the patient has either active genital lesions at the time of labor or even just prodromal symptoms, you need to do a C-section. And then the S in torches is syphilis. We cover adult syphilis in the video on sexually transmitted infections, but here we're going to talk about congenital syphilis. Take a look at the study guide and we'll do some show and tell. Congenital syphilis can cause early manifestations and late manifestations. Early manifestations are those that occur within the first 2 years of life, such as hepatomegaly and elevated LFTs, a rash followed by desquamation of the hands and feet, so the skin of the hands and the feet slough off. Snuffles, which are copious nasal secretions and often blood-tinged. And skeletal abnormalities, which can be detected by X-ray. And then the late manifestations are due to scarring or inflammation, and they develop after the first 2 years of life. These include frontal bossing, which is a prominent forehead, interstitial keratinitis, which is scarring of the cornea and can lead to blindness, a saddle nose deformity where the bridge of the nose collapses, Hutchinson teeth, which is widely spaced teeth that are notched, especially the upper incisors of the front teeth. You can see perforation of the hard palate. You can also see saber shins, which is an anterior bowing of the tibia, so they look a bit like curved swords or sabers. So congenital syphilis can cause some significant malformations, and up to 25% of cases result in fetal or early neonatal death. So it's important to prevent congenital syphilis if possible. The next question in the study guide says, what is the treatment for syphilis in a pregnant patient who is allergic to penicillins? The standard treatment for syphilis is good old penicillin G. And even in a patient who is allergic to penicillin, that is still the best treatment. So the answer is to first desensitize the patient by giving a tiny dose of penicillin in a controlled situation and gradually building up the dose until she is no longer sensitive to it, and then give the full treatment dose of penicillin. That does turn up fairly frequent on the boards and practice tests, so make sure you know it. Now, let's review various pathogens that can cause food poisoning. In the study guide, there's this question that says, what is the most likely cause of food poisoning given each of the following statements? Let's say you have vomiting for 1 to 6 hours after eating potato salad at a picnic. That's caused by Staph aureus. Staph aureus food poisoning doesn't occur because staph infects the GI tract. That would take a few days. Staph aureus food poisoning occurs within a few hours after eating the food because of the preformed toxin. You'll see Staph aureus food poisoning when the food has been prepared and then left out unrefrigerated. That allows the bacteria to grow and produce this toxin. So the patient gets sick relatively rapidly and it causes vomiting rather than diarrhea as the chief complaint. Let's say you have vomiting 1 to 6 hours after eating reheated rice. This is Bacillus cereus. Again, this is due to preformed toxin, but with rice, think of grains and cereals and think of Bacillus cereus. Vomiting and watery diarrhea on a cruise ship. It's most likely norovirus. This is extremely contagious. You can get it from another person or you can get it from the food that has been contaminated with secretions from an infected person. But norovirus is infamous for causing outbreaks on cruise ships. So if you see cruise ships, think norovirus. So there are 3 pathogens that can cause vomiting as the main symptoms. Next is watery diarrhea 12 hours after eating meat or poultry from a cafeteria. This is Clostridium perfringens. Clostridium pores can survive high temperatures, so if the meat is cooked but left out for a while, then the spores will germinate and the bacteria can grow, and after they're ingested, this will cause a watery diarrhea. Let's talk about causes of inflammatory diarrhea. If you see leukocytes in the stool, that's inflammatory diarrhea. Inflammatory diarrhea is associated with the invasion of the intestine, which causes things like fever, abdominal pain, and blood or mucus in the diarrhea. This is also called dysentery. Inflammatory diarrhea 1 to 3 days after eating undercooked meat or poultry, eggs, or produce. This is salmonella. Salmonella is the most common cause of foodborne illness, and it's been associated with tons of different foods, from fruits, vegetables, but classically, salmonella is associated with raw chicken or eggs. Inflammatory diarrhea after eating undercooked hamburger meat, followed by AKI or acute kidney injury. This is E. coli 0157:H7, which causes usually bloody diarrhea and can lead to a hemolytic uremic syndrome, especially in children. That's what causes the AKI. Inflammatory diarrhea after eating raw seafood. Think about Vibrio parahemolyticus or another Vibrio species. Inflammatory diarrhea followed by ascending paralysis. Ascending paralysis should make you think of Guillain-Barré syndrome, which is often associated with Campylobacter jejuni. You can also get this from eating undercooked poultry. What about descending paralysis after ingestion of homemade canned goods? That is botulism due to Clostridium botulinum. Improper canning allows for Clostridium spores to germinate and then produce botulinum toxin. The toxin prevents the release of acetylcholine at the neuromuscular junction, producing a symmetric, flaccid, descending paralysis. Also, know that infants can get botulism from ingesting raw honey. The baby ingests the spores in the honey, which then grow and colonize in the GI tract. Then they produce the toxin. This leads to a constipated and so-called floppy baby. Now let's discuss osteomyelitis, which is infection of the bone. There are 3 ways that the infection can reach the bone: hematogenous spread through the bloodstream, continuous spread from an established infection source like cellulitis that spreads to the underlying bone, and the third way is direct inoculation from trauma or surgery. Osteomyelitis can be tricky to diagnose. It can cause symptoms like fever and chills, pain, redness, and swelling in the affected region, and on labs you can see a leukocytosis, an elevated CRP, and ESR, but these are all very nonspecific. You will almost always see the SED rate and CRP elevation in osteomyelitis. X-rays generally aren't helpful very early on because it can take weeks for the abnormalities to show up. MRI can be useful, and you can also use a radionucleotide bone scan. But the gold standard for the diagnosis of osteomyelitis is to do a bone biopsy and culture to find evidence of bacteria growing in the bone. The most common cause of osteomyelitis overall is Staph aureus, but that's usually a good guess. In certain clinical situations, there may be a better guess, so let's look at your study guide. In a patient with sickle cell disease, the most common cause of osteomyelitis is salmonella. That's a pretty common test question too, but before you send me feedback saying how I'm wrong and Staph aureus is really the most common cause in these patients, UpToDate says specifically that in the US and Europe, osteomyelitis in sickle cell patients is usually due to salmonella or other gram-negative organisms such as E. coli. Staph aureus is the most common cause of osteomyelitis in individuals without sickle cell disease and accounts for 1/4 of all cases in sickle cell disease. And before you start complaining that I'm being US-centric, remember that the test we're preparing you for is the US MLE. They are testing you based on practicing medicine in the United States. In Africa and the Middle East, staph is still the most common cause of osteo in sickle cell patients, but in the US, it's definitely salmonella. Osteomyelitis in a patient with prosthetic devices. You need to think about coagulase-negative staph, like staph epidermidis. Involvement of the vertebrae suggests Mycobacterium tuberculosis. When TB spreads to the spine, it's called Pott's disease, which can lead to vertebral collapse and possibly spinal cord damage. Osteomyelitis following a cat bite. This is most likely Pasteurella multocida. In an IV drug user, you're still going to worry about Staph aureus, but also Pseudomonas, Serratia, and Candida. In a diabetic with a foot ulcer, osteomyelitis is most likely polymicrobial, and it can include Pseudomonas and anaerobes. You need to cover those when choosing your empiric therapy. And finally, a puncture wound to the foot through a sneaker is classically Pseudomonas. Think of that smelly, wet sneaker, and it's going to be carrying some Pseudomonas. Let's go over a few points about nosocomial infections, which is not infection of the nose. Nosocomial infections are healthcare associated infections, infections that you pick up while in the hospital. Remember, you'll get a question where they describe a patient who's in the hospital for one thing and then they develop an unrelated infection. They might ask you to guess what the most likely bug is. For instance, lots of patients in the hospital end up with an indwelling catheter for long periods of time, and this is a big risk factor for catheter-associated UTI. You're providing a pathway for bacteria to climb up the catheter into the bladder. And the longer the catheter remains in place, the higher the risk of UTI. The organisms that cause catheter-associated UTIs are basically the same ones that cause normal UTIs, like E. coli and other gram-negative rods. But you also have to worry about Pseudomonas and Candida. But E. coli is still the most common one. Patients with a mechanical ventilator can develop ventilator-associated pneumonia, specifically Pseudomonas or Staph aureus. You can also see aspiration pneumonia in hospitalized patients, especially with altered mental status because they aren't protecting their airway and they aspirate their gastric contents. Aspiration pneumonia is usually polymicrobial, but you especially have to worry about the anaerobes. Central lines or central venous catheters can also be infected, and that will cause bacteremia. The most common causative organism here is coagulase-negative staph, like Staph epidermidis. In surgical wounds or decubitus ulcers, you worry about Staph aureus. Patients receiving parenteral nutrition, which nutrition through an IV, like a patient with pancreatitis, which are high risk for candidal bloodstream infections. And when you see nosocomial diarrhea, think about Clostridium difficile colitis, especially in a patient that has been on antibiotics. C. diff is highly transmissible, so it's easy to spread it through the hospital. And when you have a C. diff colonized patient take antibiotics, the antibiotics kill off the normal flora and the C. diff overgrows, leading to pseudomembranous colitis. So next we're going to briefly look at the red rashes of childhood. The first one is very common and the one that you will hear about all the time in children. It's hand, foot, and mouth disease. Guess where it presents? This rash is contagious and caused by Coxsackie virus type A. It presents with an oval-shaped vesicle on the palms, soles of a child, and typically they will have vesicles and ulcers in the mouth as well. Hand, foot, and mouth is self-limited, and there's not really any treatment. Frequent hand washing and avoiding close contact with those who have it will reduce the spread among children. The next one is roseola. Roseola is due to human herpes virus 6 and is typically mild. It affects children by the time they're 2 years of age. The child will usually have rose-colored macules on their body after several days of sudden high fever. These are often greater than 103 degrees, and with fevers this high, they might have febrile seizures. We also have to think about measles, also known as rubeola, is caused by the measles virus, so pretty easy to remember the etiology. The child will usually have what's known as the 3 C's, cough, coryza, and conjunctivitis. They may also present with the Koplik spots, or blue-white spots on the buccal mucosa. These symptoms typically precede confluent rash of measles. Parents will report that the rash started on the child's head and then moved to the body. Rubella virus causes rubella, another easy one to remember. The patient will have pink maculopapular rash that begins at the head and moves down. Unlike measles, this rash remains discrete and leads to fine desquamating truncal rash. Scarlet fever is caused by Streptococcus pyogenes. The history is usually a patient who had a recent sore throat and fever. They will also have flushed cheeks and circumoral pallor. The child would have a sandpaper-like rash from the neck to the trunk and extremities. Although there is now a vaccine for chickenpox, this is one you should know and be able to recognize. Chickenpox is caused by the varicella zoster virus. The patient will have a vesicular rash that begins on the trunk and spreads to the face and extremities. The thing to remember is that the lesions will be in various stages. There are 4 etiologies for neonatal conjunctivitis that I want you to know and be able to recognize. They are chemical, gonorrhea, chlamydia, and HSV. Let's start with chemical conjunctivitis. These patients will have a non-purulent, watery discharge that lasts 1 to 2 days. Think of this as if there was a recent antibiotic ointment use and may have caused some irritation. With conjunctivitis due to gonorrhea, there will be marked conjunctival injection, lid swelling, and profuse purulent discharge. It lasts 2 to 5 days. Rapid corneal involvement may lead to blindness, and this one may also disseminate. Chlamydia is the most common etiology, and you'll see mild to severe hyperemia, thick mucopurulent discharge that may be bloody and last 5 to 14 days. The last one is HSV. This one presents with conjunctival injection and non-purulent discharge. You may also see keratinitis and vesicular skin lesions that lead to a disseminated infection. HSV can last days to weeks. Okay, now it's time for the end of session quiz. First question, which Torch's infection is the most likely cause of each of the following findings? Chorioretinitis, hydrocephalus, intracranial calcifications. This is the classic triad for Toxoplasma gondii. Hydrops fetalis can be seen with congenital parvovirus B19. PDA, cataracts, deafness is congenital rubella, and you can also see that blueberry muffin rash. And saddle nose, snuffles, Hutchinson's teeth, and saber shins, think congenital syphilis. Next question. An infant develops flaccid paralysis after being fed cereal sweetened with honey. Which is the most likely diagnosis? The answer is this is botulism due to Clostridium botulinum. Next, in the U.S., what is the most common cause of osteomyelitis in patients with sickle cell disease? That's salmonella. Last question, guys. A group of picnic goers develop vomiting 2 hours after eating. What's the most likely cause? Assuming this isn't alcohol related, you're going to think of preformed toxins because this is a relatively rapid onset of vomiting. So what bacteria causes those? Think Staph aureus and Bacillus cereus. So it's probably Staph aureus given that it's a picnic. But that's it for this lecture, guys. We'll see you at the next one.